Good morning. Thanks for everyone to come to the Yale IR Interventional Radiology Grand Round. So we have a special guest today. So we have Dr. Suresh Vedantham from Washington University. For those of us who are focusing on vascular disease, he's incredibly well known to all of us, so there's no introduction needed. However, I'll give you a little bit of his bio. So Dr. Vedantham is a professor and assistant dean for clinical research at the Washington University School of Medicine. He also leads the Center for Clinical Studies, which is a CTSA organization at the WashU School of Medicine as a medical director. He's also the advisor to the vice chancellor for research at the Washington University. He's a highly accomplished clinician scientist. He studied his career at the Northwestern University, where he did the undergrad, and then he finished his medical school at the University of Chicago. Did his training at Penn, UCLA, and Stanford, and was recruited to WashU, and he has stayed at WashU ever since. Incredibly accomplished, particularly in venous disease. He completed several large grant-funded studies. Currently, he leads as a national PI of a large, over $8 million NHLBI funded grant study as the national PI, and he reviews for the NIH grants as well. Over 100 peer-reviewed articles, mostly on the vascular diseases. So he's undoubtedly a national and international experts, particularly in the venous disease. He's also incredibly active in organized medicine. Whether it's American Board of Phlebology, American College of Phlebology, American Venous Forum. He has actively participated in and has been on the board of this organization, as well as Society of Interventional Radiology Foundation, Society of Interventional Radiology, several key posts, and he completed his presidency of SIR in 2018. So he has a wealth of experience, both as a researcher, clinician scientist, and the educator. Has been incredibly instrumental in mentoring a lot of young careers. So this morning, he will discuss on the DVT. I should give a plug that at 1 p.m. he's going to lead a discussion on I think that the title is a mindset and mentoring for academic radiology career. Between 1 to 2 p.m. In the Greenspan as well. It will be interesting and incredibly helpful talk. So, Suresh, thank you so much.
Well, good morning, and thanks very much. That was a very generous introduction. Thank you. Let me just find the mouse here. Today I'm going to talk about endovascular therapy for deep vein thrombosis. I know that many of you here have been near this space, and this institution has a rich tradition, really, of involvement in venous disease, really for a long time. A few disclosures here: NIH grant funding. One of the trials I'll talk about that I led was funded by both NIH and industry, and then currently research support to WashU from Cook Medical, and then a couple off-label use rotations there as well. So the real rationale for this talk really is that right now we're sort of at a transition point. You know, for many years we've been treating venous disease using endovascular means, really based mainly on our clinical experiences, anecdotes, shared anecdotes, which doesn't make them necessarily invalid, but really with a significant dearth of high quality evidence. It became almost cliche for many years to talk about, yes, we're doing this, it works, but we need a randomized trial. Over the last 10 years or so in the acute DVT area, there have been 3 pivotal randomized trials, and we now are sort of grappling with the results of these. And I think that it's very important to take stock a little bit and say, okay, what have we learned from all of this? You know, for about our patients, who should we treat and how should we treat them? The disease itself, these pivotal trials provide a great opportunity to gain more insights into the actual disease in the context of an organized program that had minimization of bias, et cetera, et cetera. We can learn about the pathophysiology, and then that can inform our future research directions. You know, and then finally, I think that as an interventional radiologist, our field, the way that we interact with medicine, really, the way that we innovate, the way that we push forward progress, really, hasn't necessarily always been through randomized trials, right? And so I think it's also a good moment to take stock of, okay, what have we learned about trying to push forward progress in this type of discipline using randomized trials? What does it mean towards our overall posture towards evidence-based medicine? So starting at the beginning then, acute DVT, it's really in the acute phase of a chronic disease. As you can see here, we know that it causes significant symptoms, leg pain, swelling. Anticoagulation works to prevent pulmonary embolism, recurrent DVT. On the other hand, the time to clinical improvement for a patient varies tremendously from person to person. Some people, their own body can dissolve their own thrombus, and they improve substantially. Other patients, the thrombus doesn't dissolve as much, and the general time course for improvement is generally weeks to months, and fully 1/3 of patients with the proximal DVT do not return to their baseline health-related quality of life, as shown in prospective studies. And we know that this is a significant issue, and it's largely related to the fact that there's thrombus, as you can see, filling this vein here with subsequent inflammation, and that sets up a whole chain of other biological processes. In the late phase, some of these patients develop something called post-thrombotic syndrome. And PTS is really a diverse condition in terms of the phenotypic presentations. Most commonly, it involves some level of chronic daily aching and or swelling of the lower extremity. A minority of patients will develop skin changes on their legs, and an even smaller minority will develop venous ulcers, such as this awful depiction that I've shown you here on the left. Now, when proceduralists like me show pictures like this, sometimes one can sense almost a drive to convince you how bad this condition really is. This is obviously the absolute extreme. I don't think that you want to go away with the impression that everyone's going to end up like this when they get a DVT. Only maybe around 5% or so of patients within a couple of years with the proximal DVT will end up with venous leg ulcers. Having said that, post-thrombotic syndrome is very common. Maybe up to half of patients have it in some form. It's the leading determinant of patients' quality of life at 2 years after DVT. And once it is developed, we don't really have consistently effective evidence-based treatments for it. So it's a significant problem. Now, it's important to consider the standard elements of DVT care. We know that anticoagulation, as I said, it reduces PE and DVT recurrence, so never should we really be talking about the idea that somehow anticoagulation is a failure. It's a big success in VTE care overall. Having said that, many patients will still develop the post-thrombotic syndrome. We do know that recurrent ipsilateral DVT episodes predict a higher risk of PTS. We do know that if you're a warfarin recipient, having a non-therapeutic INR more than half of the time predicts increased PTS risk. And so certainly preventing recurrent DVT episodes has to be considered very important in preventing this complication. Direct acting oral anticoagulants haven't really been evaluated for their PTS prevention effect. In theory, if people are able to take them and be in what you would call a therapeutic range more of the time, in theory, they may be more effective in preventing PTS, but that's not been shown yet at all. Compression stockings have been studied in several randomized trials for whether or not they prevent the post-thrombotic syndrome. And in the largest, most rigorous trial, the SOX trial that was published several years ago, they did not prevent post-thrombotic syndrome. Now, they do help people manage their swelling on a daily basis, but in terms of preventing the disease, they did not have that effect. Now, when we consider post-thrombotic syndrome and how it develops, we know that over time, when thrombus forms, there's inflammatory reaction, and that results in damage to the one-way venous valves. And in addition, the thrombus resolves variably over time. And the norm really is to have at least some residual thrombus in your veins. The larger the veins that were involved, the more residual thrombus tends to be there on average. But there's a great diversity really in the patient population in terms of how well people are able to resolve their thrombus. But the combination of reflux and obstruction combine to lead to what you could call venous hypertension. Essentially, when a patient is standing, the pressures in the venous system are higher because of both reflux and obstruction to flow. And people have shown that that kind of correlates with the clinical severity of many of the manifestations of post-thrombotic syndrome. And here on the left is a patient that's received adequate treatment for DVT. They got anticoagulated, and I think actually were on therapy for a year, but you can see they're symptomatic, which is why they're having the venogram here. And as you can see, this is a channeled vein, septated, filling defect, suggestive of clot, and lots of collateral veins. That's not a well-functioning common femoral vein, obviously. And so over the years, this idea has developed, if we more aggressively remove clot up front, can we prevent valvular reflux, venous obstruction, and ultimately the post-thrombotic syndrome? And that's really been around for a long time. And there have been randomized trials that were done in the 60s and 70s looking at systemic thrombolysis. There have been a few randomized trials, again, small, looking at surgical thrombectomy. And again, results pointing generally in a suggestive direction that there might be a benefit, but again, with very low methodological quality overall and high potential for bias in those studies. Now, catheter-directed thrombolysis evolved in the early 1990s, and with this technique, essentially a multicidal infusion catheter is placed into the venous system, and a thrombolytic drug is infused directly into the thrombus, enabling better thrombus removal with a lower dose than what's been given with systemic thrombolytic therapy. And in our early experiences, we've certainly observed that patients seem to improve when we do this. The clot certainly dissolves quickly. We're able to get the veins open. And what we seem to have observed is that patients' symptoms have improved. Now, this has led to a fair amount of extrapolation, which is absolutely understandable given the dramatic responses that we've seen. I think that if you think about the way that interventional radiologists tend to improve care, we really rely on observation, and then we sort of personalize what we do to each individual patient. We're sort of personalized medicine before personalized medicine in a sense, right? But then again, our research culture, the reliance on randomized trials, on higher forms of evidence, really hasn't been a strong part of our culture. That's true to some extent with many of the surgical disciplines as well, but it's certainly true in the interventional radiology space. And so the way that we promoted this is around maybe around 2000, let's say, was that we would show pictures of these open veins and say, well, logically, isn't this vein better than the one that's clotted? Shouldn't this patient be better? Or we would show these very emotionally evocative pictures of terrible venous ulcers and say, well, you don't want to end up like that, do you? And so this combination of logic and emotion is what we use to try and suggest that more and more people should have thrombolytic therapy for their DVT. I think that a lot of that came to a halt to some extent in 2004 with the CHEST guidelines that were published and basically almost ignored really catheter-directed thrombolysis, really, almost entirely, really. And I think we appreciated then that I think the larger medical community appreciated the risks of lytic therapy and the idea that you could just say you're going to start lysing everybody without really showing that patients are better in the long run for a therapy that's moderate to high risk like thrombolytic therapy just doesn't fly, right? And I think that we were stunned a bit by the fact that people didn't agree with us, and we were stunned that really we weren't even in the loop with these discussions, right? And I think that that led to a lot of soul searching and ultimately the development of several large-scale clinical trials. Now, it's very important to realize that the clinical scenario we're dealing with, right, that we've been dealing with for many years is actually distinct and different from what we've been doing in the randomized trials. So there are three, you know, when I get referred a patient for consideration, I think about it, I put them into three general bags, really. So there are patients with acute DVT that have limb-threatening, acute limb-threatening circulatory compromise. It's like major ceruleodomas. Again, these are just a few patients a year, but these patients certainly, they're never going to have a randomized trial, but certainly something needs to be done to salvage their limb because we know that their amputation rates are very, very high if nothing is done. At the bottom is the use of lytic therapy as routine first-line therapy. So you come into the emergency room, you got a DVT, we anticoagulate you, and let's go get the clot out because it may prevent long-term complications, right? That is a much bolder kind of thing to suggest that one would do, right? In a sense, it's a population approach, right? It's almost like a vaccination to prevent long-term problems, right? And you're dealing with a much less selected population. But we talk a lot about the post-thrombotic syndrome, and all the talks that are given on this focus a lot on it. But in reality, the reason we get called in clinical practice, okay, our colleagues, our medical colleagues, our surgical colleagues do a lot of culling for us, right, in the real world, right? An institution like this probably sees, 800 to 1,000 DVTs, acute DVTs a year, and I'm going to bet that the interventional radiology, vascular surgery, interventional cardiology, whatever sections don't lyse more than probably 50 of them, right? But that's because a lot of culling occurs. The reality is that for 20 years, the physician community has anticoagulated these people, and a minority of them get worse. They clinically get worse. The patient asks, can something else be done? Whatever it is, right? And those are the people that get sent to us, right? So remember that we have then selected out for a group of people that have a more powerful clotting process, probably, right? And that may be somewhat different than the general presenting population with the first episode or with the DVT, right? And that's a very important thing to keep in mind. From those observations that, okay, well, we can get symptom relief where nothing else was working, we sort of extrapolated and said, well, we think that based on what we're seeing, these people ought to be better in the long run, right? And the question is, can you really make that big leap, right? So 3 randomized trials got developed, and I'm going to mention that again, all of them focused on that initially presenting DVT. So you come in, you get anticoagulated, and you get randomized right away to receive or not receive intervention to remove clot. You all get compression stockings in either arm, and then you get followed over a couple-year period, right? So again, the people in the studies are a less selective population than what we have been treating in practice, but that was the whole idea. The whole idea was, should we extend from what we're doing to a much larger number of patients? That's the question that was being asked. So there have been 3 trials. I'll run through these fairly quickly. The first trial was performed in Norway. It's called the CAVENT trial. They used infusion catheter-directed thrombolysis. Park an infusion catheter, the way we used to do it in the 1990s here, infuse the patient for a couple of days typically, dissolve the clot, reposition the catheter, and at the very end, stent the vein if there's a lesion, And in that trial, what they found is that indeed catheter-directed thrombolysis seemed to reduce the occurrence of the post-thrombotic syndrome. But pay attention, it wasn't dramatic, okay? 55% to 41%, so maybe 1 in 4 cases, right? Prevented, right? 3 in 4 cases not really affected by using lytic therapy, right? And the p-value was 0.04 on that. Extended out to 5 years, that difference widened even further. That's kind of encouraging. But at no time beyond 6 months was there any effect on health-related quality of life. In addition, there was no effect on recurrent venous thromboembolism. There was a small price in terms of major bleeding. Thankfully, no disasters occurred, but a few % of patients had a major bleed. And remember, putting it into context, if you just get put on anticoagulant therapy, you're probably going to have maybe 1.5% have a major bleed during the initial phase of anticoagulation, right? So that was kind of encouraging. The ATTRACT study is a study that I led, was performed in the United States, and it was a study that involved 56 US sites, 692 patients, and we took people, again, with proximal DVT above the popliteal vein, and we randomized them to receive or not receive pharmacomechanical therapy, so drugs plus devices, the idea being that you can then aspirate clot, chew it up, macerate it, get better dispersion of the thrombolytic drug, use less drug, do it more safely, and hopefully get more clot out and get a better result. And we randomized them to receive or not receive lytic therapy, followed them for a couple-year period. Everyone got anticoagulation, compression stockings, and we assessed them for the post-thrombotic syndrome, for quality of life, safety, costs, and we did some mechanistic assessments too using ultrasound over a couple-year period. And this study, again, it involved a lot of minimization of bias. It was funded by the NIH. The NIH sets things up such that the Data Coordinating Center is funded separately by a separate grant. They don't report to the Clinical Coordinating Center. So my opportunity as a PI to let my own internal hypothesis, bias, how the data is analyzed and all that kind of thing really doesn't exist, largely, really, because the data is analyzed by a separate group. And in this case, it was the McMaster group, who has an eminent history of running venous thromboembolism trials. And so there were systematic efforts to minimize bias, comparable use of anticoagulant therapy in both treatment arms, plans for equal surveillance of patients in both treatment arms. We randomized centrally, and we stratified by the extent of clot. So people with iliofemoral DVT, thrombus in the common femoral or above, the most extensive DVT, there was an approximately equal proportion of those patients in the two treatment arms to make sure that clot extent wasn't going to bias the results. And in addition, that also enabled us to do higher quality subgroup analyses down the road. And then the assessors of clinical outcomes, the adjudicators of clinical events, were blinded as to whether or not the patient had received lytic therapy in the first place. So we had as many precautions of bias as we could come up with. Now, it was an open label trial, so both the patients and many of the providers would have known that the patient got lysed or didn't get lysed. But beyond that, I think that we did as good a job as we could in terms of minimizing bias. We were very lucky with this trial in that our timing was outstanding. The Surgeon General came up with a national call to action on DVT literally at the time the study was funded in 2008, and actually went to the step of publicly endorsing the ATTRACT trial. We had involvement actually of 3 different Surgeons General in promoting this study, which was we were obviously very grateful for. We had a number of organizations around the care of venous disease, Society of Interventional Radiology, American Venous Forum, American College of Phlebology, other organizations that really came together to push and support this trial, which is the kind of thing hopefully we'll see more of. And so we had really a big effort. It's a very, again, this wasn't something that was pushed by interventional radiologists. The steering committee, the investigator network, very diverse. Radiologists, vascular surgeons, cardiologists, vascular internists, biostatisticians, epidemiologists, health economists, etc. So a very diverse study. And what we found was that, in fact, using lytic therapy did not prevent the post-thrombotic syndrome. In fact, the numbers were almost identical, 47, 48%. There was no difference in recurrent venous thromboembolism. In the overall population with proximal DVT, there was no statistical difference in the change from baseline in quality of life over 24 months, and that's just 24 months minus the baseline. There was a small rate of major bleeding that was statistically significant, but overall not too bad in the sense that it was an additional 1.4%, which for thrombolytic therapy is pretty good, actually, in terms of major bleeds, and there were no fatal or intracranial bleeds. One interesting thing was that at every time point, we assessed and applied these scales, clinical scales, to assess the post-thrombotic syndrome. And at every time point, both within the first month as well as out to 2 years, the scores were better in the patients that got lysed, statistically better. P-value is less than 0.01, which was kind of an interesting finding, that no difference in the occurrence of PTS, but the severity of post-thrombotic syndrome and the severity of symptoms in the first month were better in the people that got lysed. We looked at a number of subgroups, and essentially the only one that came up positive was the fact that patients with who are over 65 years of age had worse efficacy. So in other words, doing lytic therapy, if anything, made them worse, and worse safety as well. So if you take patients over 65, 5 of the 6 major bleeds occurred in those patients, which came up to about a 9% rate, which is a substantial rate of major bleeding. There was a little bit of a trend towards more people with more severe symptoms doing better with lytic therapy, but that really wasn't statistically significant. Now, we did do our subgroup analyses, and the bottom line is that if you have a fem-pop DVT that does not extend up to the groin, up to the common femoral vein, nowhere in the study was there any benefit whatsoever of lysing a patient. Okay, quality of life, post-thrombotic syndrome, VTE, zip. And we looked at it upside down, really. Patients with iliofemoral DVT, on the other hand, thrombus in the common femoral or iliac vein, did not have any difference in the occurrence of post-thrombotic syndrome. So, about 50% in both arms. On the other hand, the occurrence of moderate or severe post-thrombotic syndrome was less in the people that got lysed by maybe about 40%. The proportion who developed severe PTS, again, was less by almost 50%. Health-related quality of life, venous disease-specific quality of life, appeared to be better in the people with iliofemoral DVT who got lysed. In addition, again, if you look at those scores, right, pretty much all of that difference in scores came from the iliofemoral patients, and none of it came from the FemPop patients, as far as you can tell by looking at the means, basically, okay? And so in the iliofemoral group, there was substantive evidence of some clinical benefit. And I think this is really the slide that shows it the best, This is the change in quality of life from baseline. And this was done with a lot more detailed modeling, using all the data in different ways, registering the time of the assessment to the exact date it was done, and so you get these growth curves that much more precisely represent exactly what would have happened in these patients. And what you see is that out to 1 month, in the first month, the change from baseline in the number of Baines quality of life scale points is 3 times larger in the lysis group. It's a change of 15 points versus 5 points, So a pretty dramatic change. And that's not a big surprise. You lyse people, you take a ton of clot out, their leg swelling and pain in our observation seems to have gotten better, right? Out to 6 months, again, there's a pretty pronounced difference between the two that was statistically significant. And again, the difference is of a scale that is clinically significant. When you get, though, beyond 1 year, the curves come together a bit because between 6 and 12 months, the people in the control arm catch up a bit, okay? And so if you look at the middle 2 lines here, I know that you're probably further away than I am, but middle 2 lines here, that's the FemPop patients, okay? And you can see these curves are almost identical all the way through. The top and bottom lines, the blue and the red, are iliofemoral patients. And as you can see, in the first 6 months, a pretty big difference. Beyond that point, there was a difference. It was statistically significant, but really right on the threshold or near the threshold of the minimal clinically significant difference of that scale. And so overall, we can say that in iliofemoral patients, there is a pronounced short-term benefit, but the long-term benefit is of questionable importance, right? And rated against the risks of routinely lysing people, it's hard to know whether that's really worth doing for the purpose of long-term PTS reduction. Cost effectiveness, we just published this paper, it came out just a few days ago. As you might expect, lytic therapy was a lot more expensive than not lysing people. A total of an additional $17,000 of in-hospital costs, and over the 24 months, an additional $20,000 worth of care. Again, these are costs. In terms of the overall patients with proximal DVT, the incremental cost effectiveness ratio was $222,000 per quality adjusted life year gain. And that's really low value care. When you get beyond about 150,000, that's considered low value care. So the strategy of routinely lysing everyone that comes in with a proximal DVT is poor, not just clinically, but also economically, okay? When you talk about iliofemoral DVT, you get into more of an intermediate value care, but maybe barely, 150,000 is considered the cutoff point in many assessments, and we were at about $137,000, right? And there's also more uncertainty when you go to subgroup type assessments, right? And so I think that even for iliofemoral DVT, the cost issue is still probably a factor, right, to some extent here, and more work needs to be done to really thresh this out. I'll finally mention that for those of you who were stunned at the results of the ATTRACT trial and think that, okay, well, we must have got something wrong, fair enough. There has been a third trial that was just presented earlier this year at the American Venous Forum called the CAVA trial, and they focused only on iliofemoral DVT patients using ultrasound-assisted catheter-directed thrombolysis. That's the use of the ECHOS catheter that also puts in low-power ultrasound into the clot along with the thrombolytic drug. Bottom line, no difference in post-thrombotic syndrome. And again, the numbers are almost identical to the ATTRACT trial. So they only followed people for 1 year, and they got 43 versus 45%. We followed for 2 years, we got 49 versus 51%. Pretty much identical. Major bleeding in about 5%. They infused a bit longer than we did. And if you look, they didn't do a statistical comparison here, but if you look at that moderate or severe post-thrombotic syndrome, using the same measurements that we used, 16 versus 26%. We had 18 versus 28% in the iliofemoral. So really, this trial has absolutely, it's a smaller trial, it's got its issues, but having said that, you now have another trial that really is pointing in exactly the same direction. Again, 1 year quality of life, no different in these treatment arms, So I think that it's very important for us to take stock, right, of this idea that we should be routinely lysing people as part of first line care, right? And I think that it's important for us to really try and harmonize or reconcile our observations with what we're seeing in the evidence here to kind of come to what's the truth, right? Because we know the randomized trials also have their own downsides, right? You're really looking at a little bit more of a cherry-picked population. Sometimes they're not as generalizable to real-world practice, et cetera, right? What I would say now, though, is that in 2019, if you say to me, who should be lysed, clearly routine use is not justified. We did 3 randomized trials, 3 countries, 3 different methods of lysing patients, and not one of those trials really gave us our core contention, which is that you lyse people, you remove clot, you have less PTS, and better quality of life. Not one of the 3 trials gave us that. And so these studies really did answer the primary question they were tasked to answer, is there a large difference in PTS to justify routine use? They answered that question to the best of our ability for now, over 1,000 patients in these studies. On the other hand, on the positive side, for the first time, we actually have randomized data that supports the idea of maybe what we've been doing over time, which is selective use, right? Carefully selective use, right? There was some substantial early benefit and a small late benefit for people who have low bleeding risk and have highly symptomatic iliofemoral DVT, And I think that's probably right now the most reasonable use pending further assessment. Now, I think that there could be an argument that in some of these iliofemoral, maybe the ones with the worst symptoms, maybe something else, we should be lysing them for, as part of initial therapy rather than waiting, right? But I think that additional work is needed both in the ATTRACT database to call out, okay, what are the predictive factors of the iliofemoral patients that did well versus those that didn't, and then also hopefully to do a confirmative study, because at the end of the day, the iliofemoral data was a subgroup analysis, not a prospectively defined study. Other things that we learned, I think we learned that we don't need to put a filter in to lyse people. Again, 336 people were lysed in the study. There were no fatal PEs. I think only 1 symptomatic PE around the time of the procedure. And I think it's nice to finally have some data that matches a TPA dosing regimen to a complication rate, right? It's nice to have that kind of validation around it, whether you like what the rate is or not, at least if I use this dose in this population, I'm likely to get this result. I'll mention a little bit about how we treat DVT, just the how a little bit. I think that, there's a few different methods, really a whole myriad of methods you can use. The traditional methods have involved parking a catheter, infusing a thrombolytic drug, and then following up with mechanical thrombectomy to suck out residual clot and stent the vein if there's a lesion. I think we know that if you use this technique, if you use mechanical devices, you can get it done in 24 to 30 hours most of the time. If you keep your TPA dose to the parameters in the ATTRACT trial, you'll have a relatively low rate of major bleeding. And I think, the advantages of this are that you don't traumatize the deep veins as much, right? You're really relying on the TPA to do its work, and the patient may be on the table a little bit less, right? You park the catheter, readjust it, send them back to the ICU, et cetera, et cetera. People have been using single session methods of therapy, get the clot out on the table, right? For a number of years as well. One method of using that, the angiojet, where you can pulse spray the thrombolytic drug into the clot, let it dwell for half an hour, and then aspirate the clot out and then finish up. And there are other methods and newer devices that can be used for that as well. Some of the devices are very powerful suckers, like the JEDI catheter. Some of them are a little bit more mechanically aggressive in terms of really macerating clot more aggressively to get it out. But the bottom line is that the more you traumatize the venous system, the better inflow you need to get it to stay open. you know. And so if you do this in someone that doesn't have good inflow to the popliteal vein, it's going to reclot. If you do it in someone that's got good inflow, that's another situation. But now the other side of it, right? The benefits are that you can reduce the drug dose by doing it faster, avoid the ICU monitoring and all that. But then again, the other side of it is that are you also causing more trauma to the venous system, right? And I'll allude to that in a few minutes here. Here's a case where we used an older catheter that's now off the market, but the trellis catheter for a couple hours, really, with this extensive acute DVT here, and cleaned it up pretty quickly with just about 50 milligrams of TPA, no ICU care, and it worked pretty well, and the patient did quite well. But that's not necessarily always the case, and you don't always get done in one procedure. The other final niche method we use is that in people who have very aggressive thrombus in their right atrium or in their upper intervenous cava, there's a device called the angiovac that really requires a venous bypass to be set up with the aid of a perfusionist. But this is like a surgical thrombectomy technique. It's a huge catheter that can suck out thrombus very effectively. But the good thing is that we never really had a good method of dealing with that right atrial gumbo, you know. And I think this provides us a tool that we can use in selected situations. Now I want to get to what we learned about the disease itself, getting beyond the patients and whether we lyse and when we lyse here, right? We know that about half of patients will get post-thrombotic syndrome from multiple studies. We learned that about 20% of patients will develop moderate or severe PTS. What was interesting was that I think we have come, many previous studies that were really based largely on kind of case series, suggested that in iliofemoral DVT, almost everyone gets post-thrombotic syndrome, right? But I think a lot of that was the fact that, again, in these surgical interventional series, these were pre-selected people, right? The reason people got to that surgeon or IR was the fact that they got worse, you know? And so trying to figure out epidemiologically how often does this disease occur in these people, that's not a great way to figure it out. In the ATTRACT trial, if you had a FEM-POP DVT, 44% got PTS, irrespective of whether or not they got lysed. If you had an iliofemoral DVT, 50% got PTS. And that's consistent with other studies looking at kind of initially presenting patients. You are more likely to get PTS if you have iliofemoral DVT and more severe PTS, but it's not as dramatic as we would have thought up front, okay? And it's important to keep that in mind, again, when we think about the different populations we're dealing with. And it's a good lesson for us who work on the procedural end of things, that we have to be very careful in extrapolating the population we get referred to the overall population. And then also drawing the inference that we should be extrapolating the observations with our procedures in this smaller population to the larger population. And then finally, this discordance between prevention of post-thrombotic syndrome and reduction of PTS severity is harder to understand. It could just represent some numerical thing, right, in the data. But then again, it's also possible that the mechanisms of developing PTS, maybe you've got the gene for PTS, when you get your DVT, you're going to get PTS. And it doesn't matter what we do to lyse it, right? But that maybe the mechanisms that lead to worsening of that post-thrombotic syndrome are more what we have the ability to influence by dealing with the venous system. That's not known yet, but these are interesting observations. We did do an ultrasound follow-up study in the ATTRACT trial, and we found some very interesting findings here. One is that if you lyse people, you do get more open vein segments at 1 month. That's no big shocker, right? And less residual thrombus. We found that a thrombus-free common femoral vein and iliac vein segment at 1 month predicts less post-thrombotic syndrome, less moderate or severe post-thrombotic syndrome, and better health-related quality of life. That's important. That shows that there is some validity to this open vein hypothesis. On the other hand, we found that pharmacomechanical catheter-directed thrombolysis did not reduce the occurrence of valvular reflux. And that's a bit of a shock, really. The CAVENT trial, which used infusion-only catheter-directed thrombolysis, did show some degree of reduction in valvular reflux. And so one question comes to mind is, well, maybe we got a lot of clot out, and that's a good thing, but maybe by using this pharmacomechanical method, could we have possibly caused more trauma to the venous system, more trauma to the valves, whatever, right? To where we sort of canceled that out in a sense, right? And didn't get the benefit of reducing valvular reflux. Or again, these are not the largest studies in the world. We always have to be careful about going too far with drawing inferences from studies of a few hundred patients, okay? It's always possible that's part of it as well. But I think it's clear that the open vein hypothesis is relevant. But then there are clearly other mechanisms at play. And we really need to be looking at that as well scientifically, right? Inflammation, right? The biology of post-thrombotic syndrome. How do veins get injured and sustain injury, right? What are the molecular mechanisms? There's so much more work that needs to be done that has nothing to do with the plumbing stuff that we deal with here. I think also we learned that in terms of assessing patients, there are some limitations to how we do things, right? This is a disease that affects patients every day. If you have post-thrombotic syndrome, your leg hurts, swells every day. It varies, it fluctuates. Some days are good, some days are bad. People get flare-ups, et cetera, et cetera. And in these trials, over a 2-year period, we have 4 assessments. They'll often miss one, right? So you have an average of 3.5 assessments, right? And yet they're dealing with this disease on a daily basis. Nowadays, with use of mobile technology, there are methods such as ecological momentary assessment, which is basically a way of having sensors send data to a central repository to enable you to get a much better and fuller assessment of the patient experience, right? What's happening on a daily basis? Can we collect that information and help drive our future research, Now, I think that the mechanism, this idea that an open iliac vein may be helpful to patients, is relevant to future studies here. We've all seen patients with chronic venous disease in our clinics, very difficult patients to deal with. At our end, we're often thinking in 2 ways. One is, okay, is there saphenous reflux that can be corrected, especially if they have a venous ulcer? And then secondly, is iliac vein obstruction present, and does that play a role, and is that worth correcting, right? The idea being that if you reduce venous pressures in someone that's already got post-thrombotic syndrome, can you make their lives more manageable and make them more functional? And we think about this, in someone who's got lower extremity venous insufficiency that has either had a history of DVT, especially if it's up in the iliac or common femoral vein, if they have more severe symptoms, especially up in the thigh, if they have non-phasicity of their common femoral vein Doppler waveform, or perhaps if they've had treatment of superficial venous disease, but they recur, and there's no clear explanation for why they recur, right? Then you want to think, okay, should we be assessing and understanding what's going on in that iliac vein? Could there be an obstructive lesion, a May-Thurner syndrome type lesion, a stenosis, or some residua from previous DVT or whatever? And over the last 20 years, again, lots of case series out there on the placement of stents in people with post-thrombotic syndrome. And in the case series, what you see is that about 2/3 of patients have had improvement in pain, swelling, and healing of their venous ulcers. On the other hand, this is all retrospective data, and there has not been any rigorous trials to really compare this, really in a way that minimizes bias. And so we've designed this study called the C-TRACK trial. This is an ongoing NIH-sponsored clinical trial. Yale is a study site. Dr. Char in the vascular surgery section is the site PI, and thanks very much to he and his team. But in this study, we're taking people that already have moderate or severe post-thrombotic syndrome and randomizing them to receive or not receive iliac vein stent placement, basically. All the patients involved have some level of obstruction of their iliac vein. And again, all patients are being followed. They're all receiving quality care for post-thrombotic syndrome beyond the stenting side. So everyone in both arms gets attention to compression therapy, use of compression devices if stockings aren't working. Their anticoagulant therapy is reviewed to see if it's appropriate to their DVT history. Sites can use active medication if that's what they use in their general clinical practices. And people who have ulcers are referred to a professional wound care clinic, So quality care in both treatment arms, as well as people randomized to receive or not receive iliac vein stent placement. And they're going to be followed for 2 years. And we're going to be assessing whether or not their symptom severity is reduced on a scale called the Venous Clinical Severity Score. Also looking at quality of life, cost, ulcer healing, and safety, of course. And again, this study has been endorsed by a number of organizations that you see listed here on the right here. And we're hoping, again, to develop high quality data to guide clinical practice here. Now, for some people that say, well, look, these are people that I've been stenting in my clinical practice for 15 years. Are you really telling me that I got to start taking these severely affected patients and randomizing them to possibly receive no endovascular therapy? Well, I think that it's still an open question whether this should be prime time. Can most providers open the vein? Chronic occlusions are hard, right? Will the stent stay open The primary patencies in people with post-thrombotic syndrome haven't been overly impressive, maybe 70, 80% at 1 year, right? And these people have many years to live, right? Is the clinical benefit we've seen in the short term sustained over the long term? We don't really know that for sure, right? We know that payers are interested. CMS convened a MedCAC meeting to look at this very question in 2016 and concluded that the evidence is of very low quality. There are no randomized trials in this area. Usually that comes several years before some other intervention is undertaken to constrain reimbursement for the procedures. And then finally, we know we're putting permanent devices into people, right? And that in itself just inherently is something that we need to really be looking at very carefully and thinking about and making sure that we're doing it responsibly. And we also know that now in the world of social media and rampant communication, that there can be other additional challenges that come with that, you know. I think that it's very important, even after the results of these other trials, for us to not be afraid of the truth and to get this data. You know, we need to follow the rigorous data that we've accumulated to where it leads, try and minimize our own biases in that process, question our assumptions. This is a big one, because I have lots of people say to me, well, your results in this ATTRACT trial, they aren't consistent with my observations in clinical practice, and that bothers me. And that's good that they're thinking that way, because there should be kind of a face validity test around this. But let me ask you all, okay? Who followed these patients, okay? Did the interventional radiologists follow all their DVT patients for 2 years? No. Did the vascular surgeons, do they see all the patients with proximal DVT? No, they get the ones that are referred to them, right? That tend to be the worst patients, right? Do the internists, the hematologists, whoever else, pay attention to post-thrombotic syndrome? Well, some do, some don't, right? So you tell me. I think that in our short-term experiences, we've seen people, we've lysed them, their symptoms have gotten better. I've done it for many years. I will go to the bank on that one, okay? I have seen that happen. Many of you have seen that happen. But to say to me that we have made the observation that at 2 years, people that get lysed are better than people that didn't get lysed, find me someone that looked at both groups of patients and made that assessment, right? No one did it, or very few people did it, let's say that, okay? So did we meet the observation? Probably not, okay? And really, if you look at the ATTRACT trial and the findings of the ATTRACT trial, pretty much showed us what our observations pointed at, right? In the short term, if you have a big iliofemoral DVT, you do seem to do better. In the long run, we just didn't know. And what we learned is that, you know, maybe not. So I think that more clinical observations, following people more carefully, paying attention to post-thrombotic syndrome across the medical spectrum will give us better hypotheses, you know. I think more collaboration among different specialists will give us better hypotheses, enable us to answer better questions in a better way with more expertise. I think in our own field of interventional radiology, we need more trained researchers, really. That hasn't been as much of a part of our culture of innovation, but I think it's going to be a very important thing to measure innovation, not just by the great technologies we develop, but by the number of people that we affect with those technologies in a positive way. I think there's hope and there's a model for how we succeed with this. If you look at acute stroke therapy, in 2005 or so, there was a trial called the IMS3 trial. There was a big NIH-sponsored, the first big NIH trial for acute stroke therapy, and it was negative. And everyone said stroke therapy is dead, you know, and that went for many years, actually. But subsequent to that, the technology improved, patient selection improved, guided by the first trial, and then just several years ago, 3 positive randomized trials were completed. The key points being the community did not give up on randomized trials. They just improved, learned the lessons from before, and now stroke therapy is considered the standard of care. And you know, endovascular therapy is considered the standard of care for stroke. And now we're treating the right patients because we really saw the truth. So I think that with the CTRACT trial and with other treatments, we've got a great hand to play now. The NIH has devoted $12 million in order to answering this question on behalf of the US taxpayer. You know, there's a great opportunity to improve care in patients with established post-thrombotic syndrome. We've got better tools than we ever had before. We've got direct acting oral anticoagulants that people can take more easily and be compliant with more easily, keeps them in the therapeutic range more easily. We have intravascular ultrasound, better ways of looking at the veins. We have FDA-approved venous stents for the first time this year. So we've got a great opportunity here, really, to change care for people that have this terrible condition, right? And so I think it's an honor and a privilege to scan down the results of previous trials and go on to the next trial. And if we just stay focused on the truth, I think that ultimately we will go ahead and improve patient care. So I'll stop there, and thanks. I'm going to have one last slide while we maybe take some questions. We have an app. Any of you that are lazy like me and find it hard to go to your computer and find the protocol and the name of the investigator and their email address to refer patients, if you download this app on your smartphone, you can, with a click, HIPAA-compliant click of 3 buttons, refer a patient to the CTRAC trial that you happen to see in your clinic, if any of you see these patients. But anyway, thank you very much.